Today's lecture is on short-term regulation of blood pressure with baroreceptors, chemoreceptors, and the carotid and aortic bodies. And I want to frame this the way you actually need it in the operating room, not as a static review of cardiovascular physiology, but as a practical explanation of what is happening to a patient's blood pressure in real time under anesthesia. When the number on the monitor changes suddenly, what detected it, what did the body try to do, and what will we do next? That is the guiding question for the whole talk. We will move from the basic pressure equation to the autonomic nervous system, and then through the major short-term reflexes that matter in induction, spinal anesthesia, hemorrhage, positive pressure ventilation, and positional change. This is the same title slide, but it also gives us a chance to set the mental model before we dive in. Blood pressure in the OR is never just a single number. It is the result of pump function, vessel tone, and circulating volume interacting moment by moment. So when MAP falls after induction or rises during laryngoscopy, you should not think first about a disease label. Think what changed, what sensor noticed it, and which reflex is trying to correct it. That is how we connect physiology to bedside anesthesia. The goal here is to help you recognize the reflex, predict the next response, and understand whether the body is trying to change heart rate, contractility, venous return, or systemic vascular resistance. These are our lecture objectives. First, we will explain the major factors that regulate arterial blood pressure and how they influence it. Second, we will connect that physiology to why blood pressure regulation matters clinically, because the brain, heart, and kidneys do not tolerate large swings for long. Third, we will discuss short-term regulation, which is the part you use every day in anesthesia, in the OR. The question is not whether physiology exists. The question is which reflex is active right now. As we go, keep returning to one simple framework. Arterial pressure is determined by cardiac output times total peripheral resistance. If you can identify whether the problem is pump, vessels, or volume, you're already thinking like an anesthesiologist. So let's start broadly. Regulation of blood pressure is a continuous process, and anesthesia often stresses that system more than the patient ever experiences on the ward. We change preload with induction, afterload with anesthetic depth and vasodilation, heart rate with vagal and sympathetic effects, and intravascular volume with positioning, blood loss, or fluid administration. The normal patient has multiple backup systems for maintaining perfusion. The key is that these systems work on different timescales. Some respond in seconds, others take minutes, hours, or days. Today we are focusing first on the rapid systems, because those are the ones that explain the blood pressure changes you see during a case. This equation is the backbone of the whole lecture. Arterial pressure equals cardiac output times total peripheral resistance. If arterial pressure drops, one of those components has fallen, or both have. You can raise pressure by constricting arterioles, which increases total peripheral resistance. You can also constrict large veins, which improves venous return and increases cardiac output. Or you can increase cardiac output directly through heart rate and contractility. In anesthesia, this is the practical question every time you treat hypotension. Are you dealing with low pump, low tone, or low volume? Phenylephrine, ephedrine, fluids, reducing anesthetic depth, pacing the response to spinal sympathectomy, all of those work through one of these levers. The autonomic nervous system is the main rapid controller of circulation. Sympathetic outflow is the dominant system for vascular tone and for most of the cardiovascular response to stress. Parasympathetic tone matters most for the heart, especially heart rate through the vagus nerve. In the OR, that distinction is useful. When you see hypotension with bradycardia, you think differently than when you see hypotension with tachycardia. The body is not responding randomly, it is using autonomic pathways to defend perfusion. So from here on, watch for two questions. What is happening to sympathetic tone, and what is happening to vagal tone? That simple split explains a lot of what we see clinically. Sympathetic fibers innervate essentially all vessels except capillaries and a few specialized segments. That matters because the sympathetic system can rapidly change vascular resistance almost everywhere. Small arteries and arterioles are especially important because that is where resistance is set. Sympathetic fibers also reach large veins and the heart, so they can affect venous return and cardiac performance at the same time. Parasympathetic influence is much more limited in the vasculature and is mainly important for heart rate via the vagus nerve. So when blood pressure falls, the body's fastest option is usually sympathetic activation, tighter arterioles, tighter veins, faster heart rate, and stronger contractility. That is the reflex logic you want to recognize. Here is the practical takeaway from sympathetic and parasympathetic control of the variables that drive mean arterial pressure. Sympathetic activation tends to raise pressure by increasing heart rate, increasing contractility, and constricting arterioles and veins. Parasympathetic activation mostly slows the heart. It does not meaningfully constrict most vessels. So if a patient becomes hypotensive after induction and the heart rate falls, you're often seeing loss of sympathetic tone, unopposed vagal influence, or both. If blood pressure falls but the heart rate rises, that is a different pattern. The body is sensing low pressure and trying to preserve perfusion with whatever reserve it has left. Keep linking each pattern back to pump, vessels, and volume. Now we narrow the focus from the general concept of regulation to the short-term reflexes that matter in the OR. These are the systems that respond fast enough to explain what you see in the first seconds to minutes after a hemodynamic change. That means baroreceptors, chemoreceptors, the CNS ischemic response, and atrial stretch receptors. Each one has a different trigger, but they all share the same purpose: preserve perfusion to vital organs. As anesthesia residents, you do not need to memorize them as isolated facts. You need to know what event turns them on, what direction the reflex pushes the pressure, and why that response may or may not be enough. This slide lays out the short-term regulators. The baroreceptor reflex is the first one to think about in routine anesthesia care. Chemoreceptors become important when blood flow and oxygen delivery are threatened. The CNS ischemic response is a powerful emergency mechanism when cerebral perfusion is severely compromised. Atrial stretch receptors help the body respond to changes in volume. All of these act within seconds to minutes. That time frame matters. It is the difference between a reflex that can rescue a transient drop in pressure and a mechanism that is too slow to help with an abrupt induction-related collapse. So as we go through each one, keep asking, what was the trigger and what did the body try to do first? Baroreceptors are pressure receptors. They detect changes in mean arterial pressure in the carotid sinus and the aortic arch, and they send that information to cardiovascular centers in the medulla. In practical terms, they are the body's immediate feedback system for arterial stretch. If pressure rises, stretch rises. If pressure falls, stretch falls. The brain then uses that signal to adjust autonomic output. This is the reflex you're watching every time a patient transitions from one hemodynamic state to another. It is fast, it is continuous, and in the short term, it is one of the most important defenses against sudden hypotension or hypertension. This classic physiology figure emphasizes the same point. Baroreceptors are not just sensors, they are part of a closed-loop control system. The important idea for you is negative feedback. A change in pressure is detected, the medulla adjusts autonomic output, and the resulting effector response pushes pressure back toward normal. That is why blood pressure often settles after a transient perturbation. But there's also an important anesthesia lesson here. If the perturbation is strong enough, or if the patient's reflexes are blunted by anesthetic drugs, the compensation may be incomplete. Then the number on the monitor stays low, and you have to intervene. So physiology tells you what the body wants to do. Anesthesia tells you when it is not enough. Even without extra detail on the slide, this is the right place to pause and make the framework explicit. In the OR, short-term blood pressure control is really a story about sensing and response. A sensor detects stretch, oxygen, or perfusion. The medulla processes that signal, then the heart and vessels respond. If the sensor says pressure is too low, the body raises sympathetic tone. If the sensor says pressure is too high, the body reduces sympathetic drive and may increase vagal tone. The same logic applies whether the trigger is induction, spinal sympathectomy, hemorrhage, or a positional change. Different cause, same question. What is the body trying to correct right now? Baroreceptors help maintain relatively constant pressure during changes in body posture. That is the everyday clinical example. A patient goes from supine to standing, venous return falls, central blood volume falls, and baroreceptors sense the drop in arterial stretch. The vasomotor center responds by increasing sympathetic activity, which increases heart rate, contractility, and vasoconstriction. The result is that blood pressure does not collapse. In other words, baroreceptors act as a buffer. They smooth out rapid swings. That is their job. If you want to understand a post-induction hypotensive episode or a patient who becomes lightheaded when moved, this is one of the first reflexes to consider. Another key point: baroreceptors oppose both increases and decreases in arterial pressure. So they reduce daily variation in pressure. But they are not a long-term volume control system. They adapt. That is why they are less useful for chronic blood pressure regulation. For us, that distinction matters because baroreceptors are excellent at handling fast changes, but they are not the answer to every hypotensive patient. If the problem is ongoing hemorrhage, persistent vasodilation, or true fluid loss, the baroreceptor reflex will try to help. but it cannot replace volume or fix the underlying cause. So think of baroreceptors as the rapid stabilizer, not the final solution. At normal arterial pressure, baroreceptors are active, they are already firing, and their firing rate changes in response to stretch. That means the body is not waiting for a crisis to happen. It is constantly monitoring the circulation. The practical point is that a rise in pressure increases baroreceptor activity, while a fall decreases it. When that signal changes, the medulla adjusts autonomic output. This is why blood pressure can be so dynamic during anesthesia. Even small changes in preload, afterload, or anesthetic depth can shift baroreceptor input and change sympathetic tone. That is not noise, that is physiology in real time. These receptors are especially important during rapid changes, like standing up after lying down. They help maintain blood flow to vital organs, especially the brain, by buffering the pressure change. That is why they are often called pressure buffers. If pressure rises, the reflex pulls it down. If pressure falls, the reflex pushes it back up. In the OR, the same concept applies when you see sudden changes after induction or positioning. The question is not just what the blood pressure is now. The question is whether the buffering system is intact, blunted, or overwhelmed. That answer tells you what to do next. Now, let's walk through the actual reflex arc in a simple way. Start with the trigger, a change in arterial pressure. The sensor is the carotid sinus and aortic arch. The central processing happens in the medulla. The effector response is altered, sympathetic and parasympathetic output. The clinical consequence is a change in heart rate, contractility, venous tone, and arteriolar resistance. That sequence is worth memorizing because it is the same sequence you can use at the bedside. When you see a blood pressure change, ask yourself, was the trigger a drop or rise in pressure? And what did the reflex do with the heart and vessels? When mean arterial pressure rises, baroreceptor firing increases. The medulla responds by increasing parasympathetic or vagal activity and decreasing sympathetic activity. The result is slower heart rate, less contractility, and less vasoconstriction. So the system brings pressure back down. That is the normal negative feedback response to hypertension. In anesthesia, you might see this during stimulation, emergence, or excessive vasopressor response. The body is saying, in effect, pressure is too high, reduce pump drive, and reduce vessel tone. The important thing is that this is a reflex, not a diagnosis. You still ask what caused the rise, but the body's first response is always to buffer it. When mean arterial pressure falls, the reflex is the opposite. Baroreceptor firing drops, parasympathetic activity falls, and sympathetic activity rises. Then heart rate goes up, stroke volume rises if preload allows it, and total peripheral resistance increases. This is the response you want to recognize during induction, hypotension, or after a sudden decrease in venous return. The body is trying to protect perfusion before you intervene, but there is an important limitation. If the patient is deeply anesthetized, vasodilated, hypovolemic, or beta-blocked, the reflex may be blunted. So the body may try to compensate, but not enough. That is when anesthesia management has to supply what physiology cannot. So the baroreceptor story is really a negative feedback loop. Trigger, sensor, central response, effector response, clinical consequence, pressure falls, stretch falls, firing falls, sympathetic tone rises, and pressure is pushed back up. Pressure rises, stretch rises, firing rises, vagal tone rises, sympathetic tone falls, and pressure is pushed down. This is the core short-term regulatory loop. If you remember only one thing from the reflex section, remember this. The baroreceptor reflex is fast, it is continuous, and it mainly defends pressure through the heart and vessels. That is why it is so clinically important in anesthesia. A very familiar example is moving from supine to erect. Blood pools in the lower body, central blood volume falls, MAP falls in the head and upper body, and the baroreceptor reflex is activated. The response is strong, sympathetic outflow, producing vasoconstriction and helping minimize the drop in pressure. This is exactly the physiology behind orthostatic changes, but it is also the same logic behind what happens when a patient is repositioned on the table. If the blood pressure changes after movement, think posture, venous return, and baroreceptor compensation. In many cases, the reflex handles it. In other cases, especially if anesthetic depth is high, it does not. Hemorrhage is another classic setting where the baroreceptor reflex matters. Blood loss lowers circulating volume, which lowers venous return, stroke volume, and arterial pressure. The baroreceptors sense the drop and trigger sympathetic activation. That means tachycardia, vasoconstriction, and venoconstriction. The goal is to preserve perfusion to the brain and heart by sacrificing flow to less critical vascular beds. But here again, the body is responding to the pressure drop, not replacing the lost volume. So if blood loss continues, the reflex becomes an early warning system, not a definitive fix. That is why hypotension from hemorrhage requires both recognition of the reflex and treatment of the underlying volume problem. This is the negative feedback principle in one picture. The reflex does not create a new blood pressure target, it pushes the system back toward the current set point. That is why the response is adaptive and immediate. It is also why transient hypotension may self-correct, while persistent hypotension may not. In the OR, think of the Baroreceptors as the first line of defense against sudden changes. It buys time, it is a bridge, not the endpoint. If the blood pressure recovers, the reflex has done its job. If it does not, then the underlying trigger is bigger than the compensation, and you need to treat the cause. Now let's move to chemoreceptors. These are important when blood flow falls enough that oxygen delivery, carbon dioxide, and hydrogen ion balance start to change. Because they receive high blood flow, they are very sensitive to changes in blood chemistry. When MAP drops significantly, especially below the level where perfusion is threatened, chemoreceptors are stimulated. The response is excitatory, not inhibitory. They increase sympathetic outflow. Clinically, that means vasoconstriction and redistribution of blood flow away from less essential areas toward vital tissues like the brain and heart. So, if the baroreceptor reflex is the pressure buffer, the chemoreceptor reflex is a backup alarm when perfusion itself is failing. The carotid and aortic chemoreceptors are chemosensitive cells near the carotid bifurcation and the aortic arch. They respond to oxygen lack, carbon dioxide excess, and hydrogen ion excess. When they are activated, they excite the vasomotor center and increase sympathetic activity. The slide notes that they are not stimulated until pressure falls below about 80 millimeters of mercury, and that becomes clinically useful because it reminds us these receptors matter more when hypotension is real and sustained, not just mildly low. In the OR, this is the patient who is not just vasodilated, but also becoming underperfused. The body then shifts into a stronger sympathetic protective mode. A useful way to think about the chemoreceptor reflex is this. The baroreceptor reflex is about pressure, but the chemoreceptor reflex is about perfusion quality. If tissue oxygen delivery is falling and carbon dioxide is rising, the body wants to defend the most important organs first. So sympathetic tone increases, peripheral vascular beds constrict, and blood is redirected. That is why the response is helpful in shock physiology. It is not a precise fix, it is a survival response. In anesthesia, this matters when hypotension is accompanied by poor perfusion, delayed capillary refill, rising lactate, or other signs that the pressure problem is now a delivery problem. The CNS ischemic response is the emergency backup. It operates rapidly to prevent further decrease in MAP whenever blood flow to the brain becomes critically low. When MAP falls very far, the vasomotor center itself becomes ischemic. That triggers an extremely strong sympathetic discharge. The result is intense vasoconstriction, including in the kidney arterioles, and a powerful attempt to restore pressure. This is one of the most potent activators of the sympathetic vasoconstrictor system. Clinically, you do not want to rely on this reflex. If it is active, the patient is already in severe trouble. But understanding it helps explain why the body can mount such a dramatic pressure response in profound hypotension. Atrial stretch receptors give the body information about volume. They sit in the large veins near the heart and in the atrial walls. When blood volume increases, the atria stretch, these receptors fire, and the medulla responds by reducing cardiovascular drive. The result is increased excretion of salt and water and a return toward normal volume. That happens through several pathways. Reduced sympathetic drive to the kidney, reduced renin secretion, reduced RAS activity, reduced aldosterone, reduced ADH, and increased atrial natriuretic peptide. The practical takeaway is that the body is constantly sensing volume as well as pressure. That distinction matters when you're deciding whether hypotension is a vessel problem or a volume problem. Beyond the immediate reflexes, there are intermediate-term mechanisms that work over minutes to hours. The renin-angiotensin system, capillary fluid shifts, and stretch relaxation of vessels help stabilize pressure after the first fast response has occurred. This is the bridge between short-term reflex control and true long-term regulation. In anesthesia, you may not think about these systems first, but they matter when hypotension persists, when fluids redistribute, or when vasoconstriction is sustained. They remind us that the circulation is not static. It adapts over time. Still, for the resident at the bedside, the immediate question remains the same. Is this an acute reflex problem, or are we now dealing with a broader hemodynamic shift? Long-term regulation is mainly a renal and hormonal story. Over days to months, the body controls pressure by controlling body fluid volume. The kidneys determine how much sodium and water stay in the system, and aldosterone is part of that longer-term volume regulation. The practical anesthesia lesson is that these systems do not rescue an acute intraoperative drop in pressure. They matter more for baseline blood pressure and chronic adaptation. So, if you're treating sudden hypotension in the OR, think first about short-term reflexes, cardiac output, vascular tone, and volume status. The renal mechanisms are essential, but they are not the immediate answer to an acute event. So let's pull the whole short-term story together. The main regulators are the baroreceptor reflex, chemoreceptor reflex, CNS ischemic response, and atrial stretch reflex. Baroreceptors sense pressure, chemoreceptors sense oxygen, carbon dioxide, and hydrogen ion changes. The CNS ischemic response is a last-ditch sympathetic surge when brain perfusion is severely compromised. Atrial stretch receptors sense volume. If you can outline those four mechanisms, you can build a clean differential for almost any sudden blood pressure change in the OR. That is the point of this lecture, not memorization for its own sake. Recognition, interpretation, action. Bring it back to the formula. Arterial pressure can be increased by raising total peripheral resistance, increasing venous return, or increasing cardiac output. Constrict arterioles and resistance rises. Constrict large veins and venous return improves. Increase heart rate and contractility, and cardiac output rises. If you remember nothing else, remember pump versus vessels versus volume. That framework lets you interpret the blood pressure trace in front of you. A low pressure after spinal anesthesia is often a vascular tone problem. A low pressure after hemorrhage is often a volume problem. A low pressure with poor contractility is a pump problem. The body's reflexes try to address all three, but not always enough. This is why the sympathetic nervous system is so central to circulation. It is the main rapid system that can raise pressure when needed. Parasympathetic activity matters too, but mostly for the heart. So when you're watching a sudden drop in blood pressure, ask what sympathetic tone is doing. Has it been reduced by anesthetic depth, blocked by neuraxial anesthesia, lost to hemorrhage, or is the body trying to restore it, but failing because the patient lacks volume or reserve? That question keeps the physiology grounded in real clinical decision-making. In anesthesia, sympathetic tone is often the difference between a tolerated hemodynamic change and a crisis. Sympathetic fibers innervate most vessels, especially small arteries and arterioles, which is why they matter so much for vascular resistance. They also innervate large veins in the heart. That gives the sympathetic system a broad reach. It can increase resistance, improve venous return, and support cardiac performance at the same time. Parasympathetic control is mainly about heart rate through the vagus nerve. So if a patient becomes hypotensive, the body's fastest combined response is usually to tighten vessels, mobilize venous blood, and speed up the heart. That is the integrated reflex you want to recognize at the bedside. So if I leave you with one practical mental image, it is this. The high-pressure baroreceptors in the carotid and aortic arteries are constantly watching the pressure wave and feeding that information back to the medulla. They are the first major short-term regulators of blood pressure. When pressure rises, they slow the system down. When pressure falls, they accelerate sympathetic compensation. In the OR, that means the baroreflex is often the first explanation for the immediate response you see after induction, intubation, spinal anesthesia, hemorrhage, or repositioning. Learn to see that reflex in real time, and the monitor starts to make sense instead of just showing numbers. To close, return to the central question. When blood pressure changes suddenly, how does the body detect it, and what does it try to do before we intervene? It detects stretch through baroreceptors, perfusion, and gas changes through chemoreceptors, severe cerebral underperfusion through the CNS ischemic response, and volume through atrial stretch receptors. Then it uses the autonomic nervous system to defend the brain and heart by changing heart rate, contractility, venous tone, and arteriolar resistance. That is the practical story. So when you're in the OR and the blood pressure shifts, do not just treat the number. Identify the trigger, the sensor, the reflex, and the lever. That is how physiology becomes bedside anesthesia.